So when a patient comes to see you for reflux, a lot of times they've done some of the initial steps, right? They're avoiding foods that give them trouble. They take some antacids every once in a while. But when it becomes troublesome enough for them to show up in your office, obviously they're looking for something a little bit more. We generally recommend we start with H2 antagonists, try those for 6 weeks, and then see if you can come off of them. If you can't, and the reflux comes back, heartburn in particular comes back, we recommend proton pump inhibitors. Again, 6 to 8 weeks. Generally, if that doesn't resolve the issue, then we have patients double the PPI dose. So you're doing it twice a day, once in the morning, once in the evening. Give that 6 to 8 weeks. Now that trial will be about 6 months. If you've gone through that progression, meal changes, elevating the head of the bed, avoiding foods that cause reflux, using antacids, going through H2 antagonists, and then PPI maximum dose, at this point, that patient needs a full evaluation. We do endoscopy, we do manometry of the esophagus, we do gastric emptying. We'll even check the gallbladder because that can give reflux symptoms as well. That assessment will allow us to then stratify patients. Some of those patients are going to have a mildly dilated opening, the angle of His is missing, and a TIF fundoplication will recreate the angle of His, recreate a valve that will control reflux. If your patient starts having regurgitation, that's generally a sign that there's a hiatal hernia there. So when we do the reflux evaluation, by endoscopy, we'll do some measurements. How far is the junction of the esophagus and the stomach above or below the diaphragm? How wide is the opening? And what is the Hill classification? If those patients have an opening that's wide enough, at least 3 centimeters, then we'll recommend laparoscopic repair of the hiatus in addition to the TIF fundoplication to create the valve. Because if the valve is not kept into the abdomen, then the valve is eventually going to wear out and fall apart. If that happens, let's say your patient has a hiatal hernia but it wasn't well appreciated, it's very easy to revise the TIF. It's very easy to go back in and do the hiatal repair as well because there's minimal scar tissue created when you do a TIF transoral incisionless fundoplication. Same thing with the hiatal repair. We know that when we do a hiatal repair, about 20% of those patients are going to have a recurrence of the hiatal hernia. Why does that occur? We think mainly it's heavy lifting. When they lift, they pressurize the abdomen, it pulls on those sutures, can pull the musculature back apart, okay? Again, if we have to revise that, it's actually fairly easy to do because there's been minimal disturbance of the anatomy, there's minimal scar tissue, it's fairly easy to go in and dissect around the current TIF, repair the hiatus, and then I usually recommend that you also repeat the TIF so both repairs are in their maximal form to get the best possible result.